Um, let's try and do introductions. This is Wes McCart. I'm Stevens County Commissioner, and let's just walk through the list here. Joanne, you want to introduce yourself?
Hi, I'm Joanne Napier, admin assistant for Spokane County Community Services.
Okay, Jessica.
Hello, Jessica Diaz. I'm a section manager of managed care programs at the Healthcare Authority.
Okay, Megan.
Hi, I'm Megan Atkinson. I'm the CFO at the Healthcare Authority, and I apologize, I'm on the phone right now. I've got to pick up kids, but then I'll move over to my computer as quickly as I can.
Okay, great. Cara.
Hi, Kara Reedy, Behavioral Health Ombuds for the Spokane Region of Care.
Carissa.
Commissioner McCart, are you referring to Sheree Spoke, Director of Integration for Better Health Together? Thank you.
Sorry about that. And my names keep flipping around here on me. So if I forget somebody, apologize now. Connie.
Good afternoon, Commissioner. This is Connie Mumching with Community Health Plan of Washington.
Thank you. David Nielsen.
Executive Director, Northeast Washington Alliance Counseling Services.
Okay. Gail.
Hi, I'm Gail Kogel, Ombuds for the Spokane Region of Care.
Jay.
Hello, Dr. Jay Fathi, Plan President, Molina Healthcare of Washington.
Jeff.
Yeah, Jeff Thomas, CEO Frontier Behavioral Health in Spokane.
Josh, are you on?
Josh Kearns, Spokane County Commissioner.
Okay. Justin, you want to introduce yourself?
Yes, Justin Johnson, Assistant Director with Spokane County Community Services, Housing and Community Development Department.
Okay, Carrie?
Hello, Carrie Waterland, Division Director of the Division of Behavioral Health and Recovery at the Healthcare Authority for Washington State. Good to be here.
Thank you. Kristen?
Hi, Kristen Zapoyak, Director of Mental Health Services for Spokane Treatment and Recovery Services.
Okay, Laura?
Good afternoon, Laura Schultz, Fiscal Operations Manager for Spokane County Community Services Department.
Leanne?
Hello, this is Leanne Burridge. I'm the CEO of the Community Health Plan of Washington.
Okay, thank you. Liz?
Hello, I'm Liz Perez. I'm Regional Manager for Community Health Plan of Washington.
Okay, Wilsey?
Hi, this is Michelle Wilsey. I'm the Rates and Finance Unit Manager with the Financial Services Division of the Healthcare Authority.
Okay, Samantha?
Hi, everybody. Samantha Clark, Executive Director of Strategy and Business Development for MultiCare's Behavioral Health Network.
Okay, Stacy?
Good afternoon, Stacy West. I'm the Vice President of Provider Contracting, Provider Relations, Community Relations at Coordinated Care.
Okay, Steve.
Good afternoon, Steve Perry with the Healthcare Authority, Division of Behavioral Health and Recovery, Behavioral Health Workforce Manager.
Okay, and Vicki.
I'm Vicki Goosey with Adams County Integrated Healthcare Services. I'm the administrator.
Okay, and is there anybody I missed?
My name is Suzanne Swedner. I'm with the Healthcare Authority. I'm a workforce manager for across the agency, and I work with Steve and Carrie.
Anybody else? So if anybody hasn't done this before, it's quite the challenge because as you read the names, they all move.
So, well, you did a great job, by the way.
All right. Amber Leaders was not on, is that correct?
Yeah, that's my understanding, that she wasn't going to be able to attend.
Okay, that's fine. Okay, so if she does happen to get on, we'll fit her in here somewhere. With that, let's go ahead and move on to Healthcare Authority updates. I got a whole list of people here, so who wants to start?
I will. This is Carrie Waterland. Thank you so much, Commissioner. Really appreciate it. Yes, we did. We brought a good group of folks today that we're hopeful that we can have some continued discussions on the rates and the workforce opportunities and discussions. And so with that, I wanted to, I think, walk us through the questions. We do have those folks, I think, that are really, really knowledgeable about rates. The one thing I wanted to point out on the agenda is that we do have Steve Perry included, who was able to join us today, specifically on behavioral health workforce. He's not listed on the agenda. And in lieu of Jason McGill, we have a great Jessica Diaz as well to be part of this conversation. So just wanted to do a little housekeeping on that. And I think without further ado, Megan and Michelle, is it appropriate for me to maybe give this over to you to talk us through some of these questions that are on the, oh, and Megan, I know you can't see because you're on the phone still, but Michelle, is it appropriate for me to have us walk through these 4 questions by handing it over to maybe you to help us lead through that?
Yeah. So this is Megan. I think I'll start. I am driving, so I hope you can hear me okay. And if you're getting feedback, let me know. And then Michelle can keep me honest to the actual text of the questions. But what I want to start with is just sort of the high level around sort of hitting on, what data are we considering and what are we doing to ensure, that the rates are sufficient. And so, at the high level, we build the rates off of a prior year's claims and encounters, a prior year's expenses. We adjust that for any program changes that the legislature has made. In the past few years, the legislature has made significant program changes and program adjustments on the funding for behavioral health. We also apply a trend. We work with our actuaries to apply a trend, or it's simply an inflationary factor. And then we work back and forth with the managed care plans. And then we also share information with the behavioral health providers to ensure that the data looks right, that the data looks complete, and that we've got the right set of data. Sometimes there are things that either don't come through in the data submissions or things that need explanations in the data submissions. So that big bucket of data is the primary thing that we use as we develop rates. So I guess I would say probably the 2 biggest areas where behavioral health providers can influence the rates is ensuring that they understand, as they work with their managed care partners, that they understand how to get encounters and claims into the system, and that they are working with the managed care plans on contract negotiations. So, for example, a topic that's been coming up lately is the workforce impact on salaries. And so working with the managed care plan so that they know costs are changing and that can get addressed in the rates. And then that, even if that is a new issue, right? So let's say a contract with a managed care plan changes, and so that doesn't show in our historical data, we can make adjustments for that as we build future rates. The other area where we've made a lot of adjustments recently, I'm kind of repeating myself a little bit, sorry, is as the legislature makes changes in the behavioral health funding. So then we go in and we do explicit program change steps for that. So those are the main areas in the rates where we can make adjustments or changes. We are somewhat limited in terms of what CMS allows us to build into a rate. And so it does have to be, the rate process is very data driven. I'm going to pause there and let Michelle guide me to the next big topic I need to be hitting because I can't see the words.
So I think, Megan, one of the things also, we do have combined meetings with the MCOs and the ASOs to discuss what the providers have brought back to us on their perspectives about funding. And it isn't always necessarily specific to rates. There are times when it is specific just to, you know, the crisis system or systems that we fund through the duplicate process where it goes through the ASOs and the MCOs. And some of the provisos that we have actually fund both of those. But I think, Megan, that, you know, what you said is, you know, exactly right with how answering the questions for the behavioral health provider agencies are invited to specific meetings where they can give their perspective and listen during that time. I think that answers that question. Are there other questions? Is there anything else beyond that one for the first question?
Okay, so then it sounds like I'm also, if anyone else on the call wants to ask a follow-up or wants me to hit another topic, I'm happy to you know, just sort of have a conversation with you. I'm going to pause and see if anyone else wants to kind of grab the microphone away from me.
Do you want to address the second question, Megan, which is what is HCA's plan in the future for ensuring behavioral health provider agencies are funded sufficiently to deal with the increasing operational and staffing, recruitment, retention costs to provide services to both Medicaid and eligible non-Medicaid individuals?
Yeah, thank you, Michelle. So I guess, again, I would be more succinct if I were studying and looking at the words, so I just ask a little bit of grace on this. You know, there's sort of a number of things I want to hit on, and they are not in priority order. I think the first is just clarifying for everyone, and I know you all know this, but HCA is limited by the appropriations that we are provided. And we are subject to authorized and environment oversight. And so as we work with our contracted actuaries to build rates, that work gets a high level of scrutiny from OFM and legislative staff. And so that sort of ties back to what I was saying earlier about if we make adjustments in the rates, or as we make adjustments, not an if, we do every year, as we make adjustments in the rates, they have to be data driven. It has to be linked to something, either a program change, something we're seeing in the data, something that the MCOs are telling us is changing. That we have a lot of scrutiny on our rates. So in terms of what we can do to ensure the rates are sufficient, we hit that in a couple of areas. Again, we have extensive meetings with MCOs and with the BH providers to make certain the data we're using, the data set we're using is complete and correct. We have extensive conversations and we share a huge amount of data with legislative staff so that they also understand the data that are being used for rate setting. And then we also support the authorizing environment as they do scenarios, both for the governor's budget development and for the legislative budget, that then end up being program steps, budget steps. So we are constantly in conversations with the authorizing environment around the data that are being used in rates, sharing with the authorizing environment the concerns from the provider community, and trying to help inform, you know, as an executive branch agency, we aren't allowed to lobby, so I'm not going to say influence, but inform the authorizing environment conversation. And those are the two biggest areas. We also can do budget requests, as you all well know, as an executive branch agency. We just submitted our budget request, and I just want to stress, we are in constant conversations right now with the authorizing environment around the workforce impacts that the behavioral health providers are feeling right now, and trying to help support and address a solution. And then I would also say we have in recent times in the pandemic, in the last 18 months, I feel that, you know, based on my experience in state government, the agency's been as quick and as fluid as we can, trying to support providers. You know, I would point out the Zoom licenses, trying to get equipment out, getting cell phones out to individuals so they can access telehealth, making sure that we're reimbursing for virtual visits. I'm sort of hitting a laundry list of things. We're trying to do quite a bit to be responsive and to be financially and programmatically supportive of the provider community. I'm going to pause and see if Carrie or Michelle, again, want to kind of direct me if I've missed a point.
I would like to add just that, you know, whenever we set rates, one of the things I think that is we also do is the actuaries look at the trend on both a unit cost basis. So how much is this actually costing us related to inflation and utilization? And they add those trend factors in. Now they take national statistics to do so. So that helps inform the rates as rates increase and as funding is, you know, has to be looked at to make sure that the rates keep pace with inflation, operational costs, and other things. So they look at it from that perspective as well. I think the piece about the non-Medicaid eligible individuals, we do surveys with our ASOs to ensure that we help inform the requests for additional funding for those individuals. And we've been fortunate enough that in the last couple of years, the legislature has taken a look at those non-Medicaid individuals as we recognize that the percentage of need has changed from what it was previously. We used to be able to have an impact of somewhere around 67% of our ASO funding. We could kind of estimate that. And we've seen that more and more individuals who might be on Medicare and not be eligible for those particular services, or they have a high deductible health plan. And so they don't have the same level of care as somebody who might be on Medicaid. So those are things that we do. We do surveys to our ASOs to try to elicit information to assist in obtaining additional funding. Now we can ask for that. That doesn't mean that we're necessarily going to receive it. And I see that Leanne has had her hand up. Did you have a question, Leanne?
I did, and I apologize if my question is a little naive because I'm not really in the details of the rate setting methodology. But I did want to focus on the trend aspect of setting the rates, which you touched upon. And I believe that there's a fair amount of discretion within, that there's a range that it gets built into the trend that is a bit about, predicting the future, that has to go a little bit beyond what the data might show in terms of the past trends, that there's some discretion to say that there's an increased demand for utilization based on factors such as, the pandemic and other environmental factors that we know have caused increased demand. And so I'm wondering if that's an opportunity to build in a little bit additional funding through the anticipated increased utilization that comes from the need that everybody is, pretty much aware of at this point.
Hi, this is Megan again. So I believe I can address that. I will just say that while I was on mute, I did make it through the elementary school line and got picked up. So a little bit distracted there for a moment, but I think I'll answer that by picking up on something Michelle was saying, that we look at unit cost and we look at utilization. And so when we apply trends, or kind of what I just simplistically think of as like the inflationary factors, we're looking not just at how much more expensive or less expensive, typically in healthcare, more expensive things are becoming, but also how utilization is changing. So as utilization is increasing or decreasing. And You know, while we don't usually know year to year exactly where the increases and decreases will happen, we know that they will happen. And in the areas on the Medicaid rates where we are integrated, you know, then we're also looking, while we build the rates individually, we do an integrated rate now. And so the puts and takes on the physical health and the behavioral health side, you know, as we roll the rate up to a single composite rate, we have to sort of take that into consideration as well. But you're right, Leanne, we do, to the best of our degree with our insufficient crystal ball, we try to put in the rate what is needed for what we believe will be happening in the future. And then if we find mid-year that we're significantly off, or if things change, like a program change from the legislature, you know, we just did an update to the current calendar year rates because of significant program changes. You know, so I'll stop there.
So Jeff, you have your hand up. Can't hear you, Jeff. You're still muted.
Sorry about that. Thank you, Commissioner. So Michelle or Megan, I'm not sure which one of you this is for, but I appreciate you guys mentioning the significance of workforce shortage and vacancies, you know, in the world of behavioral health providers, and how that, you know, has an obvious impact on the ability to provide services and therefore produce encounters and therefore have something that can be counted in the actuarial study. And you know, at the August 19th meeting that Millman hosted with Healthcare Authority and MCOs and providers, something was commented on that you, I think, touched on again today, which was that you know, there's not a way to count something that's sort of anecdotal. So the variable of high staff vacancies, which is very much the case across most organizations in the state, is something that there's not really a built-in way in the actuarial study to factor in, except if it goes through, and this is what my understanding, and I want to clarify, my understanding from that meeting was that it's up to providers to provide that information to the MCOs, and then for the MCOs to provide that information to Millman so that it can be factored in some fashion into the consideration of the rate setting. And my concern with that is at the time that was mentioned, my sense is that neither the MCOs nor providers were aware that that was an expectation, and I'm not aware of any process or mechanism in place for the MCOs to be collecting and passing along that information, which means that there's going to be to whatever extent that can influence the consideration of the rates, that's going to be a huge gap. So could you speak to that?
Yeah, so I'll speak to it in a couple of ways. So I would say, again, it is a typical and standard point in the rate development process that we do a data request of the MCOs, and that we do data validation with the MCOs. So that does happen every year. In terms of, you know, trying to figure out how to address the workforce shortage and both the impact that would have on encounters, i.e. utilization, right? If you have fewer providers and you just can't get the same number of encounters. And then if you're addressing trying to attract and retain staff with higher salaries or signing bonuses or something like that, then how that's impacting your expenses. You know, I'm really getting out of my area of responsibility and outside my area of expertise. But, you know, a possibility is looking at capitated or subcapitated or some type of non-encounter-based payment model between the providers and the MCOs. Because yes, if you're on just an encounter basis, then you're going to, you know, sort of end up in that spiral, right? Where you've lost staff, you can't get the encounters, then your income's contracted, and then, you know, just that spiral that everyone is aware would happen. what we run into, again, sort of from the healthcare authority's role, sort of on one hand, we have the MCOs and the providers, and on the other hand, we have our federal funding partners, CMS, and our state government authorizing environment. So we would have a very difficult time explaining to the authorizing environment if utilization is significantly contracting, why we didn't adjust the rates downward for that. Because what they would tell us is, you know, what are you paying for? Why are we paying for nothing? And I don't believe that statement, but I think probably several of the MCOs on this call right now can remember last calendar year, many tough conversations with the authorizing environment early in calendar year 2020, when we had that significant contraction on utilization, and staff and members saying, you know, why aren't you adjusting rates downward to grab back for that contraction in utilization? So it's a difficult balance for us at the healthcare authority, in that we need rates to be sufficient, and we need rates to be actuarially sound, and we need rates to cover what's going to happen in the future, right? Which is always difficult. And yet we also have to balance the expectation from the authorizing environment that we're paying for services. And I'm gonna stop now and see if anyone wants to follow on with a question or comment on that.
So Leanne, you have your hand up, and then I'm gonna ask if we can get Healthcare Authority to finish answering these questions, and then try and get a little bit more into the back and forth. So go ahead.
I just wanted to emphasize, this feels like such a catch-22, and I'm very sympathetic to the providers here, because and I would be very comfortable with some type of an arrangement where, as an MCO, we have to show that the money is going to the behavioral health providers, even if you know, the service, the encounter data doesn't reflect it, but it's through another mechanism. Because as long as the problem that we're facing is that there's downward pressure on the premiums, we're not getting sufficient premium for the behavioral health provider services, and that's because the encounter data doesn't reflect it, because there's shortages. And so it really is a catch-22. And I find it hard to believe that we can't make a case together to the state authorizing body that this is not about paying for, you know, it's not a windfall for anybody. It's trying to remedy the shortfall that is causing these shortage of services when there's an increased need. And I think that's the other piece that is very real. There is an increased need for services. And so, you know, I think together we could make that case.
Okay, thank you.
Megan, can you see
go ahead
the
and
next
move on to the next question?
Yeah, Megan, can you see it, or do you need me to read it to you?
Can you read it to me, Michelle? I'm just getting home and getting logged onto my computer, but can you read it?
Sure, sure. What is HCA's plan in the future for ensuring behavioral health provider agencies' funding is sustainable in the near term for recovering from the workforce shortage, as strategies are implemented across the state to address this shortage?
Thank you, Michelle. I guess I would say that our strategy in the near term is the same as what we've been doing, which is making sure that we're gathering the best and most complete data we have as we build rates, sharing that development as we're in rate development, making sure we're in communication with the MCOs and the providers, and doing the same work that we've been doing in the authorizing environment to both, again, share the data and make sure that we're sharing the situation that's happening out on the ground with the providers.
Are there any questions about that?
Let's go ahead and move on to number 4.
Okay, and that probably isn't, this probably is for DBHR. How is HCA addressing the behavioral health workforce shortage crisis in the short term for providers across the state? And this is probably for Steve and Carrie, maybe?
Yeah, I think, thanks, Michelle. I think I would say Steve and Suzanne and Carrie definitely, because Suzanne has been instrumental in ensuring that this is you know, really getting some attention, not only inside of DBHR with Steve and his amazing work, and I'm excited for him to talk to you about the campaign that just launched, but also ensuring that this gets eyes all the way up to Sue Birch, our director, and really aware of workforce shortages in behavioral health. And so not wanting to oversell or kind of put either Suzanne or Steve on the spot, but Suzanne and Steve, is there, you know, an opportunity maybe for us to walk folks through the idea of the sprint teams that we're forming and that kind of stuff to look at some of these needs?
Yeah, I think that's a good place to start, Carrie. Suzanne, do you want to lean into this? Do you want me to start?
Steve, go ahead and start, and then I can follow in from the coordination aspect as well.
Okay, a couple of things, and I just, this is a very small list, and the list of actually what the Healthcare Authority is doing to lean into behavioral health workforce shortages is pretty extensive, but I want to just give you some high level pieces. You know, to begin with, there recently, just a couple of months back, was about 600 plus additional, 600 million additional dollars invested in behavioral health, including a 2% increase to Medicaid rates. There is currently a new round of COVID enhancement money coming out soon. And I know there are discussions both within our agency and with our partners across the state about how, if and how these funds might be available to support workforce needs for behavioral health providers. I would say also there currently is the application for provider relief funds, which represents about 31 million, is out and available. HCA is working hard to make sure that we get that money out into the hands of providers. As Carrie mentioned, we just within the past few weeks initiated agency-wide sprint teams to focus on quick strategies that have potential for high impact. So, you know, what can be done that would be measurable within 6 months, you know, approximately. We're looking, you know, having conversations about how we might be able to use emergency flexibilities that are within HCA's authority to do so. We've made a number of investments in expanding curriculum and moving that curriculum online to make it more accessible for folks. We will be connecting the sprint team efforts to the workforce group, subgroup of MCOs and ASOs. We're looking forward to begin those conversations with our partners on, you know, to make sure that we are aligned in this work and that we're leveraging one another's efforts. Would let you know also that September 13th, we launched a behavioral health recruitment campaign to try to recruit more folks into this good work. That will run through November. We're already talking about a second phase, and you can access some of the ad material and the website landing page at startyourpath.org, all one word. And then there are a number of bills and task force that we're working on. House Bill 1504 makes a number of investments in behavioral health workforce, including increasing loan forgiveness and repayment programs. It broadens the definition of agency affiliated counselor, which really is a Medicaid billing issue that will be cleaned up in that change, and it establishes 2 pilot programs for provider community, and we're working with Accountable Communities of Health at this moment to get those monies out the door and implement those programs. We're working with one set of stakeholders to develop a teaching clinic enhancement rate for community behavioral health agencies who are training student interns, and we're working with another group of stakeholders on, to do an examination of criminal background checks on behavioral health employment. And again, on and on. We are leaning into this very heavily, and we're doing this with a lot of other state agencies and MCO, ASO providers. Suze, what did I miss?
Nothing. I'm just going to take a different angle. I'm going to elucidate a little bit more. We talked about sprint efforts. What that really means is we are taking experts and folks who work in the behavioral health workforce and behavioral health services activities across our agency and bringing them together to do some brainstorming around short and medium-term actions we can take inside of HCA to help support the workforce activities across the ASOs, across the provider organizations, and with the MCOs, as well as within our own four walls. That's really important work, and it's part of the coordinating effort that I tend to oversee. A second piece I would emphasize is important, and Steve has had a really important role in working on this, is the Health Workforce Council, part of the Workforce Training and Education Board, has still a behavioral health advisory task force that's now called to support the behavioral health assessment that they are continuing to do for the next year. They have funding from the legislature to do this work, to look at a number of recommendations around addressing behavioral health workforce issues. It's a really important piece of work. And as we head off our conversation, I'll take a look and put the link in the chat box for you. But that's a piece of work that if you're not aware of, I would suggest you go ahead and get in touch with and follow, so you can see what the broader policy directions are. Those broader policy directions are well listened to by the members of our authorizing environment. And we have, through that work, discovered many, many legislators. At the last meeting, there was a dozen legislators in the room to listen to the discussion of what workforce opportunities are available and talk about what interests they have. So there is a lot of interest in this area, I would say, and solutions are being just in the beginning of developing. Another place that I would stress to you to be interested in is we have a children and youth and families behavioral health work group that has a workforce and rates subcommittee. That subcommittee is very active and links its work to the Health Workforce Council as well as the other work of the HCA. There are folks from provider organizations, probably in your very area, who sit on this work. And I would advise you to go ahead and figure out when that is, and I'll see if I can find a schedule for that. If not today, we'll put something in the follow-up minutes. Because that work is important, because those recommendations get integrated with other recommendations from the sprint groups, from the Health Workforce Council, et cetera, into the legislators' consideration of actions on behavioral health workforce. So you can see the picture here is a little bigger than just what fits in our funding rate, which is not an unimportant issue at all. It's just, this is taking a different angle on programmatic and operational aspects of getting this work done. We are doing some work inside of our organization to develop some coordinating structures so that we can, again, track work across areas and make sure we're really emphasizing and working on things that are of priorities for you and for all of our clients. And so that's another piece that we're working on now, help support taking positive action for you on workforce. That's about it for me. Carrie, do you have anything you'd like to add?
She just chatted that she had to leave for another meeting and would send some bullet point information on 1310, and that possibly Teresa could give a high level update on that agenda item.
Yep, you bet. This is Teresa Kleekamp. Is my audio okay? I've been having issues today with that. Hopefully it's on.
Yeah, you're okay.
Oh, good. Okay, I'll knock on wood then. So yeah, I got some high level talking points, but it can certainly take back questions and concerns. 1310 is definitely one of the topics. Okay, so Alice Wadeen from DBHR is a staff member that works with the DCRs very often, and she is continuing to take any, even if it's anecdotal data or information on this issue or the impact of 1310 from both DCRs and our ASO partners as well. So she's continuing to do that, continue to have many conversations regarding the challenges with the DCR and the crisis responder providers. Allison has had a kind of a standing meeting with DCRs, and also looking at data. So we're looking at what's happening with the data with ITA investigations and ITAs as 1310 came into effect. So really looking at data. So I know they're pulling that. I would say that our ASO partners very much are bringing this up with Healthcare Authority, and in fact, it's on the schedule for our meeting next Thursday with them. So I know it's going to be a big topic there. So that's the high level. So we're basically just collecting that information and urging, you know, that this basically get well. I mean, I think we're all very wanting the same thing as far as the ASOs and the Healthcare Authority on this. So that's all I can really say at this point. I'm sorry that Carrie had to step off.
Okay, and let's go ahead and move into number 3 before I guess we get back into some back and forth here. So United Healthcare's request. Who's planning on addressing that? Megan.
Hi, this is Megan. I hope you guys can hear me. I'm on my I'm back at my desk, my home desk. I'm sorry, I'm just not the expert on this. I know that it's out there. I'm assuming Carrie was probably going to address it, but she's not here. Jessica, by chance, is this something you can speak to? Jessica Giaz?
Yeah, just very briefly, or Teresa, if you want to step in, I think that we have some efforts, or Michelle, if you're on, I think our main efforts have been trying to get out some COVID-related grants through DBHR, and those are provider specific, and there's an application process that we've been using to try to figure out that element. I think we've also been trying to do some additional collection of data to see kind of where there are gaps, as Michelle mentioned earlier, kind of maybe around the Medicaid population or folks with high deductibles. And so we're doing more collection in an effort to hopefully be able to provide more data to our legislative partners.
And I would add to that, Jessica, that we've done some very specific surveys regarding different services for things, you know, based on outreach and engagement type of things that we know Medicaid doesn't cover, because Medicaid covers services, it doesn't cover capacity. And so we've done some very specific work in that, as well as doing some work for the mobile crisis expansion in April of 2022 with the Medicaid population. As long as we can get our teams all trained up in harm reduction, trauma-informed care, and de-escalation techniques, has a capacity piece to it. So that's some of the work that we're doing on that as well. We've also done some very specific work regarding training on some of the case rate type of work that we've had, the team-based work for the PAC teams, the FEP, which is a new one, and then also the WISE teams, where we're doing very specific surveys to create documentation for the actuaries to look at, to ensure that those pieces are, anything that's capturable for Medicaid rates is put into those pieces of rates. Does that answer the question?
Yeah, and I think we made a mistake here. I thought I had heard number 4, and then I was trying to figure out why we were why there was a mention of United, and I see we're actually on bullet number 3. So
yes,
I apologize for that.
Which is United. It's the United Healthcare's request for consideration to expand.
Sorry about that. We went, I don't know, Friday brain. I apologize. So United's request at this point, we still have that pending leadership decision and discussion. We have not moved forward with that ask as of, we haven't made any decisions on that ask as of yet. We are just working with some of the other expansions that we're doing for January, which are on the along the West Coast. So Salish, Thurston Mason, and Great Rivers is kind of our focus currently. So if there was something, it would be not at least, it would be at the earliest a July 2022 timeframe. But that's something I can follow up and try to get some more information by the next meeting, if you guys would like that.
Okay. Yeah, I have several questions, and I want to move us into this item number 3 on the agenda, which is getting the provider's perspective in here. And I'm always the guy with questions, so providing a fact that I got to be chair this time, I'll just take the prerogative to go first. This is directed to the Healthcare Authority and back up on the rate setting and the communications. Seems to me that from what I'm hearing, there was a lot of conversation about, you're dealing with the Healthcare Authorities, dealing with the legislators, and dealing with CMS on one side. On the other side, you're getting information from the MCOs, which are getting information from the providers, to try and gather up for this rate setting and where we are for work shortages and all of that. And I guess what I would say is we've all played the game where we sat around in a circle and started out by saying something, and by it comes back to you, it's not even close to what you originally heard. And I guess I would ask the Healthcare Authority to try and reach out more to the providers to get direct comments on what's going on, because without impugning the MCOs whatsoever, the providers are the ones that are putting the rubber meets the road, and they're the ones that know what the work shortage is. They're the ones that know what the rates are doing and can provide you a lot of information that way. When we're paying a master's level clinician at a rate that any other master's level graduate from college could get a lot more money in a different field, and we're working with a very difficult population here, very stressful population in the behavioral health network, the amount of money that we are allowed or have the capacity to pay our employees is inadequate. And that has to factor back into, are we providing enough service? How does that come back to the work shortage? It's all part of that same actuarial study, should be part of that actuarial study. And if it's not being factored in, then I would say your actuaries are not doing the job they're doing. So that's one point on the communication. But how do we know that the rates that are coming down to the MCOs are actually getting to the providers? What's the checks and balances there?
Megan, do you want to take this one with the gain sharing and that piece?
Yeah, Wes, thank you. I will just say, we do have meetings with behavioral health providers several times during the rate development. because I understand your point about, you know, making sure that we are getting information and perspective from the people who are on sort of the front lines. And I would say, you know, we actually don't do that with any other set of providers during rate development. So that is something unique to the behavioral health area. In terms of how do we ensure that the rates that the MCOs are getting paid, that money is going out in services. So there's several components in the financial settlement and actually several components in the rate development that work to address that and be sort of the check and the balance. So the first is that we develop the services portion of the rate separate from the admin, the plan admin portion. In addition, a component of the financial deal, if you will, for the MCOs is around what we call gain share or the financial settlement component. And it limits, so first off, it includes an MLR calculation, and it limits the amount of gain that the plan can retain. So it essentially removes the incentive for the plan to retain funding that is provided them for services and retain that as either profit or margin or admin cushion, for a very inelegant term. And if the plan does retain a level of gain over what we have agreed to in the contract, then the state claws that back or settles that back from the plan. And that's probably the biggest area where we have the contract structured to ensure that the funding that is built into the rates or the funding that flows out in the rates goes out for services.
Okay, other providers, do you have perspective you'd like to be giving right now? Jeff, I knew you'd raise your hand.
Great, thank you, Commissioner. I have some remarks on, and I'll try to be as succinct as I can, but on 1310, on United Healthcare's request, and also on the workforce shortage. Related to 1310, just to share some information for the collective, in the month of August, which was the first full month that 1310 was in effect, we saw, and I think people know, but we provide the DCR detention services for Spokane County. We saw a 28% reduction in detentions compared to the first 7 months of 2021, and a 32% decrease in the number of LRA revocations compared to the preceding 7 months. So that is absolutely 100% directly correlated with the implications of 1310. The other piece I'll share that's an offshoot of 1310, and it's consistent with that about 30% reduction in detentions, is we've seen about a 30% decrease in our involuntary short-term admits to our 2 ENT facilities, which leaves unused capacity, people not getting the care they need. And from a financial standpoint, that would annualize to about a $2 million loss for us if that were to sustain, jeopardizing those resources in the long run for our community. I'm going to move on to United, and I was surprised to be reached out to by United recently with an indication that they were going to be pursuing, and we're in conversation with the Healthcare Authority about expanding into Spokane. I know that last year when Coordinated Care expanded as an IMC provider in Spokane, there was questions put out to providers such as, would an additional MCO help with the needed capacity? Would it make things easier administratively? Is now the right time? And I think the answer on our part, and I think some others, was, well, no, no, and no. And yet they were awarded an IMC contract. And I want to be clear, this is nothing against Coordinated Care. They're great to work with as partners, but more MCOs can certainly mean more administrative burden. And with United, again, nothing against United, but adding them as yet one more MCO, and one who organizations, unlike Coordinated Care, who had a statewide foster care contract, so many of us were working with them already. This would be a new contract, new additional burden and challenge and complications for our administrative burden for our staff. And I'm not sure at all what the benefit would be. In fact, I believe there would not be any benefit. I'm going to move on to workforce. And I guess I just want to share with folks, if you're not aware, the Washington Council for Behavioral Health did a survey in March related of its provider organizations, member organizations of vacancy rates, turnover, et cetera, and did a survey that was just recently completed. And the recent survey indicated, not surprisingly, that things have gotten appreciably worse in the last 5 or 6 months. Annual turnover rates of nearly 30% for all positions, average vacancy rates of nearly 20% for all positions, and of 26% for master's level clinicians. So all of which reflect things getting significantly worse. They're on a path that's not only not getting better, but it's getting worse. More than half of the responding agencies indicated that they have either had to reduce capacity, meaning turning people away who are seeking services, or close some programs altogether. And salaries and benefits were identified far and away as the primary reason people are leaving. Clinicians are leaving organizations. I just want to mention something in terms of state funding for new programs and services and how that has an implication for the workforce shortage. It was mentioned earlier, and I know this is accurate, more than $600 million invested in behavioral health services. But we talked about in our last SCIRLS meeting how every time an additional program or service is funded, then no matter how great the service may be, it's something that furthers the challenge because it waters down the workforce even more, and there's even more competition for this scarce workforce. A couple of examples: the Spokane Regional Stabilization Center, great concept, great resource, been in the works for a lot of years. Pioneers, an absolutely phenomenal partner for us on many fronts. So nothing against the concept of the partners, but absolutely that's going to create more challenges and create a still higher vacancy rate. Right now we're at 24% vacancy rate on our staff in our inpatient units. And that's just going to make it that much more challenging. At the last meeting, there was discussion of the intensive behavioral health treatment facility in Chewelah. And I know David Nielsen, who may speak to this further when he's has a chance, the competition that would create. Something was sent out from healthcare authorities subsequent to that meeting, indicating that the rates that David had seen were not, in fact, the rates that were going to be used for Chewelah. They were based on a Renton facility. Those rates had salaries of $132,000 a year for RNs and nearly $100,000 a year for licensed mental health professionals. The reassurance that was offered was, don't worry, those are the rates for Renton. They'll be different in Northeast Washington. Well, I can tell you, I work closely with colleagues who have outpatient behavioral services and inpatient in the Renton area. Those salaries are just about 2 times the salaries they are paying. So that hardly created reassurance if that salaries in our region are not going to be higher. And on behalf of my counterparts in King County and Renton area, I have great concern. A week ago, Senator Dingren and Representative Orwell visited our organization as one of the call center hubs to be under 1477. Great discussion, a lot of enthusiasm and excitement on their part and ours. And as a part of what's being envisioned and conceptualized, things like rapid response crisis teams, additional staff to provide more services, creating the capacity for next day appointments when agencies right now are turning away thousands and thousands of individuals every single day because we don't have the staff to serve them. So that to me is just as, I think, reflective of the huge disconnect, the cavernous disconnect in terms of more and more services being funded and being envisioned. And meanwhile, the workforce just is not there, and it's going to just increase vacancy rates and further compromise the ability to provide the services we currently have. Final thing I want to comment on is which has to do with sort of what I would call a disconnect. And it had to do with on the August 19 actuarial rates call. One person, I couldn't recall who, there were 70+ people on it, mentioned in an enthusiastic way and justifiably so the additional investments healthcare authorities making in law enforcement co-responder teams is an example of something positive that's occurring. Well, we're an organization that has about a dozen such positions. We're very committed to it, but 2 comments about this. As with any other new or expanded service, it does create more competition for limited staff, but much more importantly, the funding that we were awarded by Healthcare Authority as a subcontractor under WASPIC funding, and I'd like you to listen carefully to this, was for 7 co-responder clinicians. However, Healthcare Authority would only allow for salaries and benefits and a very small amount of training to be covered. It would not cover additional costs such as technology and equipment, no overhead or indirect costs, and we were denied funding to support a supervisor position. So given our entire cost of putting those 7 positions online, it's going to cost our organization nearly $250,000 annually out of our savings account. That to me is a significant disconnect. Thank you, Commissioner McCart, for your time.
Thanks, Jeff. I've got one more comment on the United Healthcare request. You know, last time Healthcare Authority wanted to expand another provider, MCO, into our region, after the fact, we were told, yeah, we should have come and talked to you first in our region. We didn't do that. We apologize. And we moved on. We gave our perspective. We said it would not be helpful. After quite a bit of back and forth, Healthcare Authority decided to go ahead and expand anyway, regardless of how our comments went. And in this case, we're seeing the same thing. We're seeing United Healthcare's request coming out. We've had no heads up from the Healthcare Authority that this was coming. We've had no conversation about whether or not it would actually help our area. And in fact, I'm going to just flat say, I don't believe it will whatsoever. You know, we knew up front there were 5 or 6 MCOs that were going to be providing services statewide. And it seems to be that regardless of what our area wanted or what would work best for our area, that we are being told you will work with all the MCOs. And I don't think that in the spirit of any of this moving forward with the way that the Healthcare Authority has on bringing the MCOs into the entire system, the integration or any of that, was it ever our intent to be told what to do throughout the entire process? And I know that's a little harsh way of saying it, but I guess the word I want to go back to the Healthcare Authority is early and often conversation with us and having a good dialogue back and forth would be very well received and respected. And we haven't seen that.
So yeah, I have to be honest with you. Jessica and I are trying to text back and forth. We have no knowledge of United coming into your region. So I don't know where the information is coming from, and we don't have Jason McGill on this call right now. So all I can tell you is we're going to take these questions and concerns back, but we have to admit we're swirling a bit because, I mean, maybe I'm just completely out of the loop, but I had no idea. We're expanding into some of the Salish Peninsula regions, and that's actually happening come January. But to my knowledge, there's no expansion for Spokane. And I have to admit, I'm completely caught off guard. And so we will, maybe I can get some information about how this is coming about. Definitely hearing your concerns, absolutely. and can bring that back to leadership. But I just want to be really upfront with this group. It's like, I don't know what you're talking about. That's unfortunately the situation.
Well, I would say that makes me feel a little bit better, but yes, please take it back.
So I apologize, and I think unfortunately there was a long list of things on this, and I have a feeling perhaps the last one got misinterpreted or didn't get read or something, because we certainly would have had Jason on this call and would have been prepped for it. And I just want to apologize that I'm texting Jessica, and I don't know about this. And Jessica, I don't know if you want to say something. Maybe there's so much going on. Maybe there's something we missed, but we wouldn't roll this out. Like we wouldn't, yeah.
Yeah,
anyway.
I will say, I know informally they mentioned something around that. I was not aware or am not aware of any formal notices. I thought maybe I was missing something, which was why I said I'd take it back to Jason. But it may be that they are, before they do that formal notification, they were trying to get some contracts in place with the behavioral health providers so that they would have that adequate network when they came to us and said, hey, we have this adequate network and we'd like to enter. But we will definitely follow up and take these concerns up the chain of leadership here at Healthcare Authority. And I think we can commit to more conversation before anything would progress. I think with the comments and the way things went down last time, as you said, we should have come earlier. I think if we're in this situation again, we will take a different approach and take your comments. Going off of what we said is, we should have. So this time, if it comes to that, we will do that and bring that back to you guys.
Okay, thank you. David Nielsen.
So just as a reminder for people who don't know me, I'm the Executive Director of New Alliance, and we operate in Ferry County, Stevens County, and Lincoln County. In terms of a statewide provider, we're a small fish. I think we're a big rural fish here in Eastern Washington, but we're a small fish. So I can tell you that I have been reached out to by United Behavioral Health, only an email, no telephone calls, asking us to sign a contract so that they could expand into the region. Got that email last week. And was frankly shocked to get the email, and communicated quickly with Kathleen Torella about this. And I believe that Kathleen did reach out to Jason. And I think that Jason's response was something along the lines of, we've heard about this. So I want to echo Jeff's sentiments that, again, nothing against coordinated care, but at the time that the expansion occurred with them, we were caught off guard, and we agreed that the 3 questions that Healthcare Authority asked about expansion were all no, just as Jeff said. And I think that for my organization, I feel even more strongly about that at this point than I think I've ever felt before, for a combination of reasons, not the least of which is workforce shortage. But administrative burden is profoundly impactful with each MCO that is added on to us. And to be frank, without calling any names out, I have an IMC contract with one of the Medicaid IMC providers that to this day is still not in compliance with the state's template for what those Medicaid contracts should look like. Specifically, I'm required to report my encounters within 6 months, not 12 months. We've been fighting with the MCOs for 12 months, over 12 months in some of these cases, to get the contracts adjusted. And all I am met with as a small rural provider appears to be stonewalling. Lots of promises that things will get fixed. They are never fixed. It frustrates me as a director of a behavioral health agency to continue to tell the Healthcare Authority, this is burdensome, it is not effective for us, only to be met with another MCO wanting to come into the region to, quote, improve things. It is not an improvement, it's a degradation as we go over the course of time. Second comment, following Jeff in regards to 1310, we operate a 16-bed inpatient evaluation and treatment facility here in Stevens County. In the month of September, I have been at 60% capacity all month. Just like Jeff, we are seeing significant reductions in referrals for services. I would also directly link that to 1310. Third, in terms of workforce shortage, my staff shortages, particularly for master's level clinicians in Stevens County, I think is probably some of the highest in the state. We're at 60% vacancy. And while I appreciate some of the healthcare authorities' comments about attempts and efforts that are being made to address this, the bottom line is that none of that makes it down to me at the provider level. So for example, the 2% increase that's been discussed, we haven't seen a penny of that. And in one MCO's instance, they sent me a contract that said, here, we're going to give you the 2% only to take money out of a different line in the contract. So there's no net growth. And at the same time that we're seeing that, I think I mentioned in our last SCRILS meeting that our general medical liability insurance over the past 2 years has increased by 240%. Just in terms of the healthcare that benefits that we're going to be providing to our agency, doubling this year compared to what it was last year. And so the comments about here's the money that is coming into the area to help address this, grossly inadequate compared to the reality of what we're experiencing boots on ground here. It's discouraging and frustrating. And like Jeff, we are hearing the reason people are leaving is salary and benefits. So it's a real issue, boots on the ground here, and it remains very concerning. And at this point, I think there's a lot of good intentions, but nothing that has really been impactful. I do want to point out, though, that the ACO is the only organization that has been coming to us saying, what can we do to help? And we're having a meeting in the next week to talk about some of the dollars that they're going to be trying to infuse into the system. So when we talk about how IMC is going to be so helpful, it's going to improve the quality of things, we are not having those conversations with any of our MCOs, and I'm not trying to criticize or slam them. I'm just pointing out the reality is the communication in terms of how do we problem solve does come with ACO, come through the ACO with dollars attached to it. We're not getting that from any other organizations. Thank you.
May I ask a clarifying question? When you refer to the ACO, are you referring to the Accountable Community of Health?
I'm sorry, the ASO, not the ACO. The
okay, ASO. Thank you. Yes. Thank you. Too many acronyms.
My fault. Sorry.
Any other providers have any comments they'd like to share before we move on? Okay, I'm not seeing any hands. So let's go ahead and move on to item number 4, which is 5476 and 1477. Justin?
Yes, thank you, Commissioner McCart. Just wanted to give a brief update. This was to be provided at our last SCRILS meeting, but we pushed it forward to this one due to the topics that need to be discussed. So just briefly, in response to 5476 and the State versus Blake, certain money came down from the legislature and passed through the Healthcare Authority that is going to be pushed out to the ASOs and our region. So we wanted to give an update quickly on that piece of it. There's a lot of changes in the legislation regarding different efforts. So I'll defer to the Healthcare Authority on the different efforts they're putting forward on 5476, but very specifically on the contract put out to the ASO. We are finalizing our report for this Recovery Navigator program, which is a transitional and diversionary support for individuals experiencing SUD and SUD need within our regional service area across our 6 counties, and assisting them in accessing SUD treatment, either from an inpatient setting, community-based setting, really any setting in the community. And although insurance and the individual's coverage is something we're going to be identifying, it is not a disqualifier for the use of the service and for the provision of the coordination of care, case management, and engagement. And so we're hoping to roll this out in a more formalized manner. We still have to submit a finalized plan to the Healthcare Authority for October 1. We do believe that once we get that approved, we'll be pushing this out to our provider networks and then implementing this. The substantial amount of funds were awarded to the Spokane region, recognizing the unique needs across our frontieral communities. And so based on that and the amazing support provided by Healthcare Authority in recognizing that, we have close to $3 million to be able to invest directly in this program. And the way we're looking to invest is 2-part. We want to ensure that we, again, are mindful of workforce shortages. So it'll be a investment that looks at leveraging existing resources while building on into the future. Well, at the same time, we need to ensure that the funds get out there. And so that is 2 parts we're going to be looking at pushing to our providers You'll be hearing more about this once we get the finalized plan from the state, but that's just a quick update on that program. And with 1477, this is a much longer discussion and plan. This is in conjunction with the ongoing work for the 988 implementation as a part of House Bill 1477. A lot of work on the state side, Department of Health and Healthcare Authority. Our small part is working very closely with them to ensure that the information necessary to provide for those provisional services is provided, and in conjunction that our representation for our frontier rural communities is paramount. And as such, Spokane ASO has been selected to be on the CRIS committee to be able to provide that unique perspective from our rural communities. So we'll be reaching out to our crisis providers and regional leaders to get more information to provide this in the coming months and years as they begin developing this plan. So a lot going on, working very closely with Frontier Behavioral Health, which is our regional crisis line and identified as a hub for one of the 3 hubs in the state. So again, very close partnerships for our region and recognizing unique needs faced here. So that's just a quick update. Any questions from the group on that?
I'm not seeing any hands raised, Justin. So why don't you go ahead and move into the 1388?
Excellent, thank you. So in accordance with 1388, the regional interlocal leadership structure was developed and has been humming along. Well, we recognize that the stipulations within that statute are termed in December 31st, 2021. And in that terming, the legislation allows for the interlocal leadership structure to continue upon the structure and organization agreeing that it's necessary for the region and they want to continue in whatever form that they deem fit. So based on that, we're putting it forward to the group. Come December 31st, 2021, we have one more meeting scheduled out for December. Is this something as part of the SCRILS group that we want to continue in its current format? And is this something we see as beneficial and helpful? And is there a commitment from the county leadership as well as the provider organizations and healthcare authority to continue to come together in collaboration to address the issues? And we recognize this is a big topic to cover in less than 10 minutes. And so what we've done is created a survey for the membership to provide feedback. And in the survey, we'll hit all those topics. Do we want to continue in the current format? Do we want to change the format? Or do we want to stop it altogether? And then we also have a question regarding, will a second ad hoc meeting in November be necessary to discuss what that would look like if we needed to go in more depth in this conversation? So I wanted to throw that out there. We will be sending out the survey immediately after this meeting to get feedback. The goal is then to report back to SCRILS. If the ad hoc meeting is not requested, then we'll discuss the results there at our December meeting. If it is, then we'll plan to push forward with scheduling that, especially with the busy schedules of our commissioners and healthcare authority, to ensure that we have everyone at the table for November. So I will turn it over to the group if there's any questions or concerns or opinions they want to share.
So Justin, I noticed the agenda says 12:01:21. I take it that's an error.
That is correct. I believe we were still scheduled for having the meeting in December, although the expiration in the legislation says 12:01. We were still scheduled to have a meeting in mid-December, so we were still planning on that, which is why we said that 12:31 would be the finalization of our current structure. Although I do believe it is correct, the legislation has specified 12:01.
Thank you. Are there any other questions? Okay, any public comments from community stakeholders? Not seeing any hands. All right. Well, looks like our next meeting is going to be December 3rd, unless we have to schedule another one in November. for your conversation there, Justin. So with that, if there's no other comments, we'll stand adjourned. Thank you, everybody.
Thank you.